Hi, this is Michael Altus, and we are continuing our discussion on the physiology of blood, and this is recording part 12. When we interview patients, one thing we want to know about is if they have any problems with hemostasis. We may ask if they have a history of excessive bleeding during surgical procedures, dental procedures, blood draws, even with brushing or flossing teeth, or unusually heavy menstruation. This would be a question for the patient or any family members. Any history of nosebleeds, blood in the stool, blood in the urine, or easy bruising. Any history of a blood transfusion, and for what reason. Any problems with primary hemostasis, like superficial bleeding or bruising in the skin or the mucosa. Any issues with secondary hemostasis, which may present as deep tissue bleeding, bleeding into joints, hematomas, or hemorrhage. Laboratory tests may be useful. We could look at the platelet count, which tells us their platelet number, although it doesn't tell us if the platelets are working. Normal is 150 to 400. Thrombocytopenia is below that number, although surgical bleeding usually doesn't occur until we get into the 50s or below, and spontaneous bleeding occurs at a range of 10 to 20 or below. There is a test called bleeding time, which can detect thrombocytopenia or platelet function, but it's not very specific or reliable. It involves a cut on the patient's arm and measuring how long it takes to stop bleeding. There are platelet function analysis or platelet aggregometry tests. They could distinguish between dysfunction due to antiplatelet medications or other dysfunctions. Not a very common test. Secondary hemostasis can be evaluated through labs. The first is the PT, the prothrombin time, normal about 12 to 15 seconds. It reflects the extrinsic pathway. The lab adds tissue factor to collected blood and measures how long it takes until clot forms. PT will be prolonged in patients with vitamin K deficiency, taking warfarin, or with liver disease. Now we see a lot of PTs are run together with an INR. INR is basically the ratio of measured PT to normal PT. It varies a little bit from lab to lab, but a normal INR is around 1. The PTT, the partial thromboplastin time, is normally 25 to 35 seconds, and it reflects function of the intrinsic pathway. For this to work, the lab adds a negatively charged surface or phospholipid to collected blood and measures time until clot forms. The PTT will be prolonged in patients taking heparin, patients with antiphospholipid antibodies, patients with hemophilia, von Willebrand's disease. Also, if the blue tube is not filled all the way, the amount of activator in the tube will be too much for the sample that you gave them, and this could lead to a mistakenly prolonged PTT. For this reason, blue coagulation tubes need to be filled to the line. Patients with factor 12 or kallikrein deficiencies will have a prolonged PTT, but they actually don't have any clinical bleeding. Another test, which we talked about in the pharmacology curriculum, is the ACT, the activated coagulation time, which is good for measuring heparin activity and gauging protamine reversal. It's not as sensitive for other deficiencies affecting the intrinsic pathway. There's something called mixing studies where they take normal plasma and add it to the patient's plasma and then repeat the same PTT or whatever study again. So if the patient has a deficiency like hemophilia or vitamin K deficiency, then once you add normal plasma, they should have a normal test result. But if they have some sort of inhibitor or anticoagulant, then adding normal plasma won't have any effect. So sometimes patients with abnormal results will be sent, or their blood will be sent for mixing studies to try to determine the cause of the abnormality. Fibrinogen is something else we can measure with a normal value between 150 and 400, and problems usually below 100. Fibrinogen will be depleted during DIC, and it's normally increased during stress or surgery. So a patient who's in critical illness and has a fibrinogen of 150 may actually have a relative deficiency, since we expect it to be increased during stress. We mentioned before that fibrin is degraded into degradation products, and so those degradation products can be measured in the blood. Sometimes people measure D-dimer, which is a product of cross-linked fibrin and shows this presence of a mature thrombus, which might indicate the presence of a PE or a DVT. One lab test that we'll discuss briefly, but is becoming more common, is thromboelastography, TEG, or rotational thromboelastometry, or ROTEM. This is a graph that shows how a clot functions over time. It helps us understand platelet function, coagulation, and fibrinolysis all in one study. The idea is to fill a small cuvette with blood, and then you make the piston inside of it rotate. Slowly, blood will start to form fibrin strands. As the fibrin strands form, it becomes harder and harder to rotate the piston. That's detected by this recorder, which measures the torque in the wire. And so what we see here is, initially, the piston can rotate very quickly. Then after some period of time R, clot starts to form. As clot starts to form, it becomes harder and harder and harder to rotate, and we see much tension, which is described by the width of this thromboelastogram. Then, eventually, fibrinolysis occurs, the clot starts to break down, and it becomes easier and easier to rotate again with less torque. So we can see here, intrinsic pathway, speed of clot formation, which tells us about thrombin and fibrin. We can see amplitude of the curve, which tells us clot strength, and return to baseline, which tells us rate of fibrinolysis. Here are some examples of thromboelastography that shows us a normal clot versus a hemophiliac who has a long onset to clot, thrombocytopenic who has a slightly delayed onset to clot, but not a very strong clot, increased fibrinolysis where the clot is broken down very quickly, and hypercoagulation where we have early and very strong and very prolonged clot formation. We'll stop here and pick up again in the last recording.